Welcome, candidates, to this high-yield explainer on mucopolysaccharidosis type 1, classically known as Hurlers syndrome. I'm Professor A, joined by Professor B. Today, we're dissecting one of the most elegantly testable lysosomal storage disorders in your entire postgraduate medical curriculum. For those of you targeting NEET PG, INI SET, or UPSC CMS, this topic is absolutely critical. It sits squarely at the intersection of biochemistry, genetics, ophthalmology, orthopedics, and radiology.
Precisely. By the end of this session, you need to be able to distinguish Hurler from Hunter, Morchio, and Sanfilippo syndromes in a matter of seconds. Treat this explainer as your definitive clinical blueprint.
Let's quickly outline the syllabus for this revision session. We'll progress sequentially through the biochemical basis, the phenotypic spectrum, radiological findings, diagnostics and management, a comparative differential, and we'll finish up with a rapid-fire MCQ drill.
Starting with Section 1, the biochemical basis, which is the absolute foundation of lysosomal storage. Physiologically, we need specific enzymes to degrade glycosaminoglycans, which you might know by their older name, mucopolysaccharides. When these enzymes are deficient, undegraded glycosaminoglycans progressively accumulate within the lysosomes of your connective tissue, viscera, and central nervous system. This creates a massive, multi-system pathological cascade. Let me interrupt right here for our first major examiner trap. Candidates frequently conflate mucopolysaccharidosis with mucolipidosis. Please do not make this category error. MPS involves defective degradation of glycosaminoglycans. In sharp contrast, mucolipidosis, like eye cell disease, involve defective enzyme trafficking. Examiners love to use this subtle distinction to test your fundamental biochemistry. Spot on. Now, let's look at the specific core defect of MPS type 1. The defective enzyme here is alpha-L-hydrogenase. It's encoded by the IDUA gene localized to chromosome 4p16.3. You need alpha-L-hydrogenase for the stepwise breakdown of two very specific glycosaminoglycans, dermatan sulfate and heparin sulfate. You must commit these two substrates to memory. Their toxic accumulation explains the entire multisystem phenotype we're about to explore. Before we leave genetics, lock in exam trap 2. This is a heavily tested inheritance rule. All mucopolysaccaridosis are autosomal recessive, with one singular, vital exception: Hunter syndrome, or MPS II, which is X-linked recessive. If a clinical vignette describes an affected male with unaffected parents and a maternal uncle with similar features, the examiner is pointing you straight toward Hunter, not Hurler. Never confuse the two in a family history question. Moving to Section 2. The phenotypic spectrum, spanning from Hurler to Shy. You see, MPSI isn't a single rigid presentation. It exists along a clinical continuum, and this spectrum is determined entirely by the degree of residual enzyme activity in your patient. Looking at the extreme ends of that spectrum, we have Hurler syndrome on the severe end. These infants present between 6 and 24 months, suffering from progressive intellectual disability, coarse facial features, historically called gargoylism, corneal clouding, and tragically early mortality, often from cardiorespiratory issues in their first decade. On the attenuated end, we have Shay syndrome. This presents much later, in the second decade or adulthood, featuring normal intelligence and much milder somatic findings. Which brings us to exam trap 3. Anchor heavily on this. It is the single most tested clinical differentiator, intelligence status. Hurler syndrome causes profound intellectual disability. Sky syndrome features perfectly preserved normal intelligence. If an exam vignette specifies normal intelligence alongside coarse facies and corneal clouding, they're absolutely steering you towards Sky syndrome. Let's move to Section 3, radiological findings, specifically diasostosis multiplex. The skeletal radiographic pattern in MPSI is a highly unambiguous, image-based topic. Examiners absolutely favor this, so you need to recognize these patterns instantly on a film. The essential radiological hallmarks here include a J-shaped or boot-shaped cella-turcica on a lateral skull film. In the spine, look closely for anterior beaking of the vertebral bodies, classically at L1 to L2, producing a thoracolumbar kyphosis. A chest radiograph will show oar-shaped ribs. They're widened anteriorly and narrowed posteriorly. And finally, the hands will demonstrate bullet-shaped phalanges with proximal tapering of the metacarpals. Now here is exam trap 4. You must distinguish the vertebral beaking of Hurler from that of Morchio syndrome, or MPS-IV. Morchio classically shows central or anterior beaking with universal vertebra plana and odontoid hypoplasia. This creates a severe risk of atlantoaxial instability and cervical cord compression. It's a critical pre-anesthesia implication for Morquio that Hurler syndrome simply lacks. Moving right along to Section 4, Diagnostics and Management. A systematic approach is required here. We'll review the sequential diagnostic algorithm, followed by the 2 primary disease-modifying therapies that make up our standard of care. The diagnostic algorithm operates in 3 distinct tiers. Step 1 is urinary glycosaminoglycan quantification. This is a screening test that detects elevated dermaton and heparin sulfate. Let me be explicit. This is a screen, not a confirmatory test. Step 2 is your gold standard confirmatory investigation, measuring alpha-L-iduronidase enzyme activity in peripheral leukocytes or cultured fibroblasts. And finally, Step 3 is molecular genetic testing via IDUA gene sequencing. Once the diagnosis is confirmed, management relies on 2 main modalities, and you have to establish a rigid boundary between them. First, we have enzyme replacement therapy, or ERT, using larinidase. This improves somatic features like visceral organomegaly and joint mobility. Second, we have hematopoietic stem cell transplantation, or HSCT. This is the treatment of choice for the severe Hurler phenotype to halt central nervous system decline. But be aware, it carries a strict timing window. It must be performed before 2 to 2.5 years of age, prior to significant neurocognitive deterioration.
And that brings us to exam trap 5. Do not assume ERT is a panacea for severe Hurler syndrome. Laronidase does not effectively cross the blood-brain barrier. Because of this, ERT cannot prevent or treat neurocognitive decline. If a question asks for the treatment of choice in severe MPSI with cognitive involvement, the answer is HSCT, not laronidase.
On to Section 5, the comparative differential. To truly master this topic for your entrance exams, you have to systematically contrast MPSI with the other high-yield lysosomal storage disorders. Context is everything in a multiple-choice examination. Let's review this comparative differential matrix. Note the distinguishing traits carefully. MPSI, Hurler, presents with corneal clouding and intellectual disability. MPS II, Hunter, is X-linked recessive and characteristically lacks corneal clouding. MPS III, Sanfilippo, is marked by severe central nervous system decline. And MPS IV, Morquio, features normal intelligence but severe skeletal disease and atlantoaxial instability. Memorizing this matrix is simply non-negotiable. Here is exam trap 6. Sanfilippo syndrome, or MPS III, is the classic mismatch vignette. It presents with severe behavioral and CNS deterioration, but with very mild somatic or skeletal findings. Examiners exploit this disproportionate presentation to make sure you're analyzing the full clinical gestalt, preventing you from just pattern matching based on coarse facies alone.
Finally, Section 6, the rapid-fire MCQ drill. We've established the foundation, so let's initiate the high-stakes testing phase. This drill will simulate the pressure of a single best answer examination. Professor A will present the clinical vignettes, and I will walk through the answers.
Question 1. A 10-month-old infant presents with coarse facial features, hepatosplenomegaly, and progressive developmental regression. Urinary GAG analysis shows elevated dermatan and heparin sulfate. What is the definitive confirmatory investigation? The answer here is the measurement of alpha-L or duronidase enzyme activity in leukocytes or fibroblasts. Remember, urinary screening is never the definitive answer.
Question 2. Which MPS subtype is inherited in an X-linked recessive pattern and characteristically lacks corneal clouding? The answer is MPS II, Hunter syndrome. As we established earlier, this is the sole exception to the autosomal recessive rule that governs the rest of the mucopolysaccharidosis. Question 3. A child with an MPS pattern skeletal dysplasia requires general anesthesia for surgery. Which subtype mandates mandatory cervical spine imaging beforehand to prevent cord compression? The answer is MPS IV, Morquio syndrome. This is due to the characteristic odontoid hypoplasia, which leads to atlantoaxial instability. Excellent. That completes our rapid-fire drill. As we close this explainer, I want to leave you with a final, provocative clinical thought experiment. If a patient presents with classic Hurler somatic features, coarse facies, corneal clouding, dysostosis multiplex, but their intelligence remains perfectly intact, how exactly does this alter their clinical diagnosis and therapeutic trajectory? Consider this deeply.
It forces you to permanently cement the phenotypic spectrum distinctions between Hurler, Hurler-Scheie, and Scheie syndromes, and it dictates whether you would prioritize ERT or HSCT. Master these distinctions, review that comparative matrix, and your diagnostic precision will be absolute. Thank you for joining us in this high-yield revision session. Keep refining those differentials, and we'll see you next time.